Welcome, everyone, and thank you for joining us. I'm Drew Schiller. I'm the co-founder and CEO of Validic, where here at Validic, what we do is we take all the personal health data that you capture in your daily lives, and we bring it into the clinical workflow to help healthcare providers deliver better, more proactive care. And true to today's topic, yes, we use AI for that. Welcome to our 2025 Trends webinar. This is, we're titling it From GenAI to GLP-1s. We would just want to cover really what are the big trends that are happening. This is going to be an interactive conversation today discussing key healthcare trends. I'd like to thank my distinguished panelists for joining me. And if you're joining us live, we look forward to your participation as well. There's going to be time to answer questions. So we have a little Q&A bucket here that you can post your questions into. And we'll keep your eye on that. And feel free to just pepper them in while we go. I'll try to weave them into the conversation. We'll also have time at the end. And if you're watching this on a recording and you have a question, feel free to send any questions to hello@validic.com and we'll get those answered for you. So with that, let's get started. Just thinking about preparation for this webinar, I can't remember a time when I was sitting at the end of February and so much of what could happen in the fall and the rest of the year was a question mark. It's like things are really up in the air in a lot of important ways in healthcare right now. We have, I think leading that, we have philosophically different leadership than what we had previously in, Health and Human Services, the FDA, CMS. Telehealth reimbursement is once again at risk. Federal research grant funding may have been changed forever. Health equity is now a bit of a four-letter word in some circles of our government. There are also some good things happening too that we're looking at. AI, I think, has really reinvigorated digital transformation and innovation. Tech-savvy patients now have more access to healthcare information than ever before, thanks to Dr. GPT and direct-to-consumer healthcare brands. And the consumer voice is louder than ever with large health systems and plans. And today we're going to have a discussion from three perspectives about what all this means. You've already heard a bit from me, and now I'd like to ask my fellow panelists to introduce themselves and tell us a little bit about your role by answering the question, what are you thinking about today in your role that you weren't thinking about 5 years ago? Or, given my opening, maybe even 5 months ago. So, Tracy, why don't we start with you?
Sure. Thanks, Drew. I'm Tracy King. I'm the Executive Director of Value-Based Care at Boston Medical Center. We started this program a couple of years ago to focus on the patients in our risk-based contracts that are now representing about 50% of the patients we take care of. And in terms of doing that work, the things that I'm thinking about now that I wasn't thinking about 5 years ago really are tools that have changed from nice to have to things that I think are now essentials. Among those are tools that enable virtual care, so televisits and remote monitoring devices, which we used to have as a nice accessory, but really are now core to the work we do. I think in addition, in primary care particularly, which is the focus of my work up to this point, a team of providers in the primary care space, as opposed to really focusing exclusively on a physician or nurse practitioner only practice, because for access purposes and in a world of dwindling primary care resources, really having a full suite of people who can help patients is critical. And then for us also seeing patients in a very integrated way. Our patients are looking to be seen as a whole person. We can't call them about the one thing that's a problem or missing from their clinical profile and care. We need to really look at the whole portfolio of what the patients need and try and help them navigate that in the least disruptive way possible.
Yeah, absolutely. Thanks, Tracy. All right, Matt, what are you thinking about now that you hadn't been before?
Hey, good afternoon, Drew. Hello, everybody. My name is Matt Roman. I have the pleasure of serving as the Chief Digital Strategy Officer of Duke University Health System. And in that role, I'm responsible for things like our virtual care platform, our telehealth, our remote patient monitoring, our hospital at home ideas, communications with patients, our portal, and things like this. As I'm contemplating 5 years ago, we are within a very couple of weeks of 5 years to the day of when, as Drew mentioned, I'm in Durham, he's in Chapel Hill. We're in what's known as the Tobacco Road, of course, and college basketball hotbed. 5 years ago, almost to the day, the NCAA basketball championship was canceled. The Masters tournament was canceled. The NBA playoffs were canceled. It was that week that sort of gave me my, if I'm allowed to say, oh shit moment. And so since then, so much has happened. Of course, we came through COVID, public health emergency, the introduction of ChatGPT and some advances of generative AI and such. So given those very significant events, my thinking has transformed from, what can we conceive of in telehealth to how do we grow and sustain the impacts of this program. To add to that, Drew's comment about the sort of uncertainty in today's political environment and regulatory environment. So those questions become really existential at this point. How to effectively advocate for the benefit that we've learned and the advantages that we've gained in the last 5 years, I think are different today than were apparent 5 years ago. And also how to ask better and more effective questions of large language models and how to train these models and maximize the impact of them going forward. It's a bit of a, sort of how to bring Industry 2.0 or fusion concepts into healthcare. That's really what I'm spending a lot of my thought cycles. And it's a fascinating place to be. So I look forward to the conversation tonight.
Yeah, it is awesome. Yeah, thank you, Matt. And thanks, Tracy. And, so as a reminder, I'm Drew Schiller. I'm the CEO and co-founder of Validic. And, what I'm thinking more about today than I was 5 years ago, and I love that you brought COVID, that initial COVID wave into the conversation, Matt, because that was certainly, the thing that I'm thinking about now more than ever before was that, 5 years ago, I was really thinking, how do we introduce the concepts of remote virtual care to health systems so that they can really start to understand the benefit? And today it's, okay, now that the benefit is understood, how do we actually weave this into care on a daily basis in a way that really helps clinicians drive better, more proactive care without being something else to do, right? Because we can't ask our frontline workers to do more. That's just not going to be something they can do. So, Tracy, with that, I'd love to start with you kind of following on that. At Boston Medical Center, it's a safety net hospital. You rely, I think, a lot on state and federal grants for funding, and you serve a lot of immigrant, unhoused, and impoverished communities. I know we discussed before, and transportation access to care is at the center of your organization's innovation. And we now have the prospects of some of your patients perhaps dangerously delaying care due to fears of being picked up by the U.S. Immigration and Customs Enforcement. How is your organization just thinking about reaching your patients today when, they may have already been difficult to reach? How do you deliver more proactive healthcare in this current environment?
Yeah, thanks, Drew. It's a really good question. And it's true. Our patients have had lots of challenges in accessing care even before the current moment. So, right, we're grateful to have established some platforms to be able to reach them prior, and we'll be doubling down on those in the coming months, depending on how everything rolls out. But we do a lot of different kinds of outreach to patients to connect them with care. We do a lot of old-fashioned phone calling, but we multilingual care navigators who are skilled in motivational interviewing, trying to engage patients who may have not felt ready to engage with the health system. And they start with acknowledging the barriers that those patients may have and not assuming that the persons that they are on the phone has their health at the top of mind. So trying to help them navigate some of the other barriers to getting care. We offer telehealth visits and a lot of remote patient monitoring, mostly administered by nurse practitioners and pharmacists. So getting to your point about the broader team engaging with those patients. And we've begun some pilots with texting to engage patients who are, many of whom, the vast majority of our patients have access to texting and prefer that to a telephone call if we can engage.
Yeah, that multimodal approach is really important. And, Matt, I know Duke serves as a safety net for some of your patients as well, and you have a big engagement program. Any thoughts to add to what Tracy was saying?
Not much, except to say that I've never, ever experienced a staff meeting where we have to go through with our frontline staff and the registration people how to react if ICE or other law enforcement agencies present at the clinic, and we have had to. And it's
right. It's the beginning of every conversation. Yeah,
that is a really interesting and frankly just additional burden onto an already stressed system, right? For us to be having those conversations. So yeah, thank you for having those conversations and for bringing it into this one. From access to care, I think a big rise has been consumerism and folks really starting to advocate for themselves, especially perhaps not so much quite the population you're talking about, Tracy, but more of the well or better educated populations. And so, the rise of GLP-1s in particular, I think has really accelerated the boom in direct-to-consumer healthcare prescriptions for companies like Hims and Hers and Ro and Fridays. And it's actually really interesting because just at the end of last week, the FDA took the GLP-1s off the shortage list from the major drug manufacturers, which puts some of those direct-to-consumer offerings potentially in jeopardy, which I think is going to be really a fascinating space to watch because compounding might be going away. But I think the broader point still stands, which is that consumers are now getting prescriptions from everything from weight loss to hair loss to hormone therapies, sometimes paid through insurance, but often just paid out of pocket or through their HSA and FSA dollars. This direct-to-consumer relationship, Matt, I think poses a potential threat to traditional healthcare organizations like Duke Health. And, first because patients are able to get their prescriptions, online with that their healthcare provider isn't aware of. But second, because patients, may end up opting for more convenient online care in the future rather than going to a clinic. So I'm curious how you think about this evolution in the direct-to-consumer health. How do health systems remain relevant for all of the patient needs?
Oh, it's a wonderful question, and we do spend a fair amount of time thinking about these very things. I would argue that that it's not really new or particularly even unique, given just the evolution of consumer-driven healthcare. For us, as a tertiary care or referral center, like so many across the country, we have a non-trivial number of patients that come to us for on-referral basis or for specialty care or procedural medicine and things like this. And their primary care might not be within our network, very not uncommonly at all. And so we're accustomed to trying to understand all the care that a person gives or receives, rather. So we're aware of medicines that they're taking, and we're in search of potential conflicting interactions and things like this. So development of online tools and these convenience care programs isn't just part of this. The problem may be more prominent, though, and maybe even more threatening, but there are precedents for this, and what we can learn from these online and direct-to-consumer providers, not unlike what we learn from other industries, travel and hospitality and different things. We can learn from these convenience care, digital-first ecosystem providers, things like convenience, things like experience, things like the personalization. Might be chief among them, personalization of the care itself. We should and can and do learn from their portal design, from the usability of their tools, how to provide access and grant access to the providers, lowering barriers to care. We in a specialty care facility oftentimes want to see the patients that we want to see. And perhaps we have some opportunity to open the top of the funnel a little bit. Based on a consumer-driven experience, it's also important to realize that when the care needs escalate beyond what Hims and Hers or beyond what an online tool can offer, there still needs to be a place like BMC or Duke Health or places that do offer the full portfolio of services and can take care of a person who has specialty needs, tertiary needs, quaternary needs. And so we certainly have a space. We have a place that won't go away, one hopes, and we have some responsibility to the patients that we serve.
As you say, in our population, the majority of our population are not going out of network for care.
Yeah, totally. I will say that the interesting thing for me and what I'm really interested in watching is the nature of on-demand in every aspect of our life is now available for some in healthcare. And, how does a health system that typically schedules things out weeks or sometimes months react in an on-demand setting, right? I think it's a really interesting space to watch. And, it's like Netflix for healthcare, right? Like people are going when they want and they're getting what they want. And it might not be healthcare, but
it's an intervention.
It's an intervention. That's right.
Yes, exactly. Right. And we are challenged with some of that and finding ways to respond, but there are also limitations that we have to accept too.
Yeah, totally. So thinking about more of that consumer-focused care, Tracy, I know that with the population you're serving, using remote devices like blood pressure monitors and glucose monitors and weight scales is a really optimal way to help reach your population and get care for patients when they're outside the hospital. So, what are the opportunities you see, and also some of maybe the challenges with technology adoption, as well as, how do you pay for this?
Yeah, thanks. Yeah, so I would say that we have seen lots of opportunity to, patients are very receptive. Patients of all ages really are very receptive to using remote care, both online visits, but also remote patient monitoring. And they really welcome and appreciate the fact that we can see that one of their challenges is just to carve time out to come and take care of their health if they have to come to a central clinic location. So they very much appreciate this, and many of them have devices that are enable them to engage with us. So we're trying hard to use that opportunity. In the case of blood pressure monitoring, for example, one of the things it's really helped us do is to distinguish between what's called white coat syndrome and a truly elevated blood pressure. And what we have found is that when we send patients home monitor or follow them through self-monitoring at home, there are a number of patients come off of the hypertension diagnosis, and we therefore then don't have to prescribe unnecessary medication, which is a positive for everybody. And in addition, it gives them a tool to be engaged in a way that they can't if they really have to come to the what we call the mothership for care. The challenges are that while manual cuffs are, the frontline manual cuffs are affordable comparatively, and in our state at least are covered by the Medicaid program, not so much by commercial plans. They're easy to procure and easy for patients to learn to use, but to get the readings from those monitors requires either a phone conversation, which is labor intensive and also challenging to connect with patients, but also, or the alternative is the patient then has to log into their, hit the EMR portal and record there. So it's a little awkward in that way. The Bluetooth and cellular enabled devices that we're piloting with blood pressure are fabulous, both for patients love them and the clinical team loves them. Feeding the data right into the electronic health record. At the moment, they are not covered by insurance, and the budget for purchasing those devices is out of range for programs, many programs like ours. So that is the challenge. I think it's a modality we'd really love to expand, but it's got its financial challenges too.
Absolutely. And your patient population probably isn't one that could necessarily afford an out-of-pocket for these devices.
They cannot most of the time, no.
Yeah. I think that's a really interesting point. Matt, building on that, there's a question from the audience that I want to get your thoughts on, specific to the devices. And it's, what is the thinking of payers and providers around investing in this area to help bridge the gap in both access, so using the personal health devices and AI, et cetera, as well as the overwhelm of providers experiencing this crisis of access? Like, what can we do, or what is being done to help, get the device in people's hands, use smart AI triage, et cetera? This is emerging space. I'm just curious your thoughts.
Is the question specifically around remote monitoring types of devices?
It is.
Is that right?
It is, yeah. It's pushing access via AI and people into the home with in subacute health management.
Yeah, and there's a couple of things there. First of all, as you're asking the question, the first thing that comes to mind is the difference between a consumer grade and a medical grade device. And we actually spend a fair amount of time validating the data that come from the devices that we actually put in patients' homes when we believe the patients need remote monitoring. Now, that said, the single lead EKG that Apple has on their watches has some utility. It is not the same as a 12 lead EKG that is done by our cardiology clinic. It's really a matter of making certain that we don't create false equivalencies, understanding the validity of the data that are provided and how to use them, how to use those data. So there are certainly some applications for these types of consumer grade devices that we just need to be very aware of and very smart about how to use them, and take the data for what they are and not for what they aren't.
Yeah,
is an important consideration, I think.
I think that's a great point. Tracy, anything to add to that?
No, I think not all parts.
Yeah, I think that's a really great point. And building on that a little bit, Matt, One of the opportunities that I see with remote devices is having better data in the hands of clinicians to provide more comprehensive patient care and, help build better pre-visit summaries, et cetera. But it's not enough to simply present more data. Busy clinicians need the synthesis of the data, which is actually why here at Validic we launched generative AI summaries for remote patient monitoring recently to help really summarize quickly what's going on. But I often remind people that AI is a tool; it's not a solution in and of itself. And there have been numerous reports recently that have stated that generative AI actually slows clinicians down. I actually heard a funny story recently about how a system was exploring using generative AI to make a doctor's clinic note be more humanly readable because the physician shorthand was actually so robotic. So I thought that was a really interesting use. But you at Duke have been a leader for using AI in healthcare for years. I'm just thinking about, what is the evolution ahead of us? Like, I wonder if you can share your thoughts and perspective about how you think about AI in healthcare. What are the real opportunities for AI to positively impact care today? What's not quite yet ready for prime time? What are we getting wrong?
Yeah, there's a lot of qualitative questions there. Like I'll probably stay away from what are we getting wrong, but offer a couple of thoughts. We are first and foremost interested in and very focused on what we're considering responsible use of AI tools. Some of my colleagues at Duke are thought leaders in this space in establishing governance and establishing when to use tools and how to evaluate the models on which they're trained, not only the original training model, but also the continued use of such models. So folks from Duke and Mayo and some of the Hopkins and some of the other Stanford, other large academic medical centers across the country are really out front in some of these things. We, and speaking maybe for myself here, are taking an approach perhaps where looking for opportunities to apply these tools and learn from the application of these tools a ring or two away from the direct involvement in patient care. For instance, there was an article that was published last year, an health economics article that posited that there's somewhere between 250 and 350 billion with a B billion dollars in savings per year by cleverly applying AI tools to back office functions. It's remarkable. Things like supply chain, HR, policy management, technical support, transactional phone support, and things like this. We have done some things like applying an AI agent on top of our own policy manual. Duke is not a large health system, but we have 3 hospitals and we have, a couple hundred ambulatory sites and such, and therefore we have a lot of policy. And so we spend a lot of time, not only our compliance office, but also each individual person looking at our policy manuals for something that applies. And so we put an AI agent on top of this. And you can ask this agent how to make a ham sandwich and it'll say, I don't know. But you can ask this agent about, use of antibiotics in the perioperative space, and he'll give you an answer that's really appropriate and refer to the actual policy at hand. So it's really fascinating. We're doing some things in transactional support, like tools for assisting callers, tools to deflect the need to actually call. If our call agents are only manning the phones from 8 to 5 and Monday through Friday, and the person has some needs on a Saturday afternoon about a scheduling opportunity or such, then we have some artificial or augmented intelligence agents there. I think there's a long future, a long and very rich future to, augment clinical expertise in search of what I would consider to be signal over noise. For instance, Drew, in the RPM type of data, I once had a very clever clinician say, the patient that has a normal, reasonably normal or largely normal glucose reading, if you graph that for me over a month, it looks like just a single big block of data, right? There's a lot of noise in that signal, but occasionally there are highs or lows that are actually going to be really telling to the clinician, the provider. So I do think there's tools, there's ways of developing these tools to sort through the sort through the noise in search of the signal that then the human can act on. And that's what I'm hoping for.
Yeah, I totally get that. And I think that, I like the journey that you took us through with it, starting with back office, non-clinical, right? Starting with a bit of the low-hanging fruit, if you will, around one of the big cost drivers of healthcare that's not related to patient care. And then, it's clear though that we're probably decades or maybe centuries away from having an AI doctor like Star Trek Voyager, right? Like that's not gonna happen anytime soon, and nor should it, right? I think there's a big opportunity for AI to help humans actually be more human in healthcare by taking.
Really interesting. Yeah, I don't know how many corners we have to turn around until that is real, but the pace of change is faster than I've ever seen it and accelerating. So, George Jetson is not out of the realm of possibility, perhaps, but I do think we have to be clever how we get there.
Yeah, absolutely. So Tracy, building on this generative AI discussion, when we were in our prep session, we were talking about how English is not often a comfortable language for a lot of your patients, and even if it is, English literacy levels, that was a really funny word to stumble on. All of this represents, I think, a big challenge in medical literacy. And we talked about how generative AI could potentially help solve some of those challenges. But first, could you just take us through, like, what are those challenges that some of your patients experience? Then maybe we can talk through live, like how we could address those.
Sure, and I'm happy to do that. Right, this is a challenge that we think about quite a lot here, because I think for most of us, the materials that describe why a patient should pursue a particular intervention and how they should conduct themselves in either putting on a cuff and taking their measure or completing a fit test or whatever the material is, are written in ways that generally make sense to medical professionals, but really they make much less sense to the average person. Much more challenging for people for whom English is not a first language, but even there have been a lot of studies to show that even the average high school graduate in the United States has a real challenge understanding of the instructions that they get in medical terms. And so for as long as I can remember, the aspiration has been to produce the medical materials at somewhere between a second and fifth grade reading level, regardless of the specific educational level of the actual patient. We need to make sure that there are translations available for the written and sometimes often for the spoken patient in their preferred language. So where we are, probably there are 5 active languages that are necessary on a regular basis for the populations that we're taking care of. And while translations themselves are important, it's also important to balance between the strict translation and what's a kind of culturally competent translation, right? In a way that really speaks to the patient language they can understand. We have had experiences where even a person who's very fluent in a non-English language does a translation for us, and the medical translators will look at it and say, there are a couple of things here that really don't describe, they're not accurate. So I think, to your point about AI as an assist here, I think it is absolutely true that translation using AI tools would be a great assistant, probably get us a first draft that's really much more efficient than asking someone to do the painstaking work of translation. But because of the challenges in what language is actually going to speak to people, I think we still need human translation to augment what the AI tools can do. And so we're working on all of that now.
Yeah, I think that, I think it's such an important point. I'm reminded back in 2019, my wife's a clinical psychologist here at UNC, and she does research on how mood disorders in women around transition changes in their life cycle. And she actually, as part of a grant, went to Zimbabwe and was working with frontline nurses there to help them provide care and write a treatment manual for them for women with postpartum depression. The challenge there was, though, that you could not say depression because you actually would get hospitalized there, and not hospitalized in a helpful way. I mean, you'd be sent to a penitentiary type of thing. And so they actually had to sort of talk around the issue in a culturally competent way to help the women understand what was going on and for the nurses to provide the best care without directly naming what we would say, right?
No, exactly.
Yeah.
There are lots of examples of that. We have found that using patient groups that we talk to about how to share this material, we learned that really if we talk to patients about colon cancer screening, they were not going to engage, but colon health screening, they will. And so we've changed our language just to make sure that it resonates with people.
Yeah, that's so interesting. And Matt, I was struck by one thing that you said in our in the calls. We were discussing this as well, though. When we were talking about this concept, I think I'm trying to remember exact quote. Is something like, "Don't let perfect be the enemy of better," or something to that effect, right? Like in certain circumstances, it might be better to have a translation into something they can at least read, even if it's, I'm thinking about a long tail language translation challenge, right?
Yeah, I love Tracy's comments about not only language literacy, but also clinical or medical literacy. That just makes such an important distinction. And I think it's really important to wonder about the opportunity or the possibility of, some interactive tool. Not everyone, even with the same level of literacy, consumes information in the same way, right? So for one person, they like a didactic exchange, a question and answer, and an augmented agent can provide that. For another person, they're a deep reader, and maybe you can offer prose that for a different person who doesn't want to read and just likes the cliff notes, you can shorten that prose into just that cliff notes. And that interactivity, that personalization, I think is actually somewhat important. It's really hard to personalize that when you're an individual human clinician trying to manage hundreds or thousands of patients, but an augmented agent perhaps can supplement there.
Yeah, that's great. Well, thank you for that. And Jeff, by the way, posted in the Q&A, he says, as a resource for or reference, the American Heart Association has some translations for home BP in Spanish, which I think is a really great resource. Jeff, thanks for sharing that.
And we do use those, and the patients do really find them very useful. So thank you. Yes, that's a great point.
Oh, yeah, that's great. Yeah. Matt, all right. Oh, by the way, before I do this, I just want to say, so we are getting ready to open up for questions from the audience. We're going to have one question around AI and driving the cost down in healthcare, which I think will be a fun one. But please feel free to post your questions in the Q&A, and we'll answer as many as we can. So Matt, we haven't really yet talked about telehealth, which feels like it's perennially an existential crisis. Don't know if it's going to survive the next 30 or 45 days or so. Probably will. Don't know for how long. But what should telehealth's role be in the traditional healthcare system? I mean, some patients find it more convenient. A lot of people still prefer to go to the doctor. How has Duke implemented telehealth? How do you see it evolving? Will your views on telehealth change if the reimbursement goes away?
Telehealth and in-person medicine is not an either or, it's a yes and, as far as I'm concerned. We've settled on about 10% of our ambulatory volume being virtual and synchronous. And so there's another small bit of that is virtual and asynchronous. Drew, you call it annual existential or perennial existential crisis. And right now it's more often than perennial.
That's true.
It's really fascinating. Our government affairs colleagues with whom I stay in very close touch, as you might imagine, suggest to me that no one on the Hill, no party, no individual wants to be the one that's responsible for taking this away from providers and from patients. Our data shows that we have a very even representation of the patients demographically, and that's age and ethnicity distribution, who received virtual care as our larger population as receive care in our clinics. So this is not an issue. This is an equalizer, I think, is the point that I would suggest. It is an equity equalizer. And while that might be a bad word in the administration today, it's still something that's really very important to me, to provide good quality, equitable care to all of our patients.
Yeah, absolutely.
There is. You ask how's it part of our future? To me, as a traditional bricks and mortar health system. It's actually part of our growth plans. If in fact we have some stability, knowing that there will be reimbursement for and appreciation of the tools that we offer. I can stand up a new clinic and it might take 4 or 5 years and millions of dollars in capital and CON and all this, or we can better use the actual physical footprint we have, and then also offer some growth through virtual care. So yeah, it's in our future. I hope.
Absolutely, yeah. And Tracy, what are your thoughts as it relates to BMC? I know you have a different economic model there a little bit.
Different model, but again, echoing what Matt said, I think it's everybody in our population. It's a good representative population in those who like the telehealth visit as our overall population. And so we have started to make even greater use of it. I think we in the clinics themselves, I think our virtual visits is very similar to what Matt quoted, but in the value-based care team, we're really trying to engage patients who have, for whatever reason, not been engaged or have gaps in their care. Telehealth has been a real gift because for many patients, the social barriers to getting to the provider are really a significant part of why they are. So we do offer both telephonic and telehealth visits with nurse practitioners and pharmacists, a lot of times focusing on patients with chronic conditions. And in terms of whether we get paid, it's variable, but a very significant portion of the primary care patients that we take care of are paid for through the Medicaid model. And in the state of Massachusetts, that's a capitated model. So virtual visits really make a great deal of sense as a way to stay in touch with patients, both who have real logistical issues and other life issues that really prevent them from coming to see us, but also because we can engage other members of the team to do the telephonic engagement, and they can take some time to teach patients and answer questions in a way that a physician might not be able to do. So it's been a very big gift for us on chronic condition management in particular.
Yeah. Andrew, can I add, again, I mentioned that we aren't a particularly large system, but since the beginning of the pandemic, we've conducted about 1.5 million, almost 2 million telehealth visits. And we capture data on these visits, and those 1.7-ish million telehealth visits equates to about 20 or 30 million miles saved in driving for the patients. And so that's the opposite of a regressive tax. The telehealth visit is a progressive benefit to the lower socioeconomic scale because they don't have to pay to travel. They don't have to pay to park at our facilities. They don't have to take a day off from their job to come to the doctor. They can do these things virtually, and that's non-trivial. That is a very real impact, positive impact on the lives of the patients that we care for. And we capture data on the visits, both from the clinician's side and the patient side. And one of my favorite questions that we ask always is, were you able to accomplish your goals of your visit? And we measured on a 5-point Likert scale, and we are historically 4.5, 4.7, 4.8 out of 5, both clinically and from the patient side. I think it's really, really telling.
I mean, that's just a huge win-win. And there's a question from Aubrey in the audience on this, which I don't have the answer to this. I don't know if either of you do, but Aubrey asks, you touched on CCM, the chronic condition management. Can you touch on how the new Medicare telehealth rules will impact us past March 31st? And I think that's where we don't know yet, right?
If I could answer that question, I could quit my job probably and go into this. But no, I wish I could, but we are sitting on the edge of our seats like everyone else waiting to see where we can apply it.
Absolutely. Yeah. It's a big question mark. And I think that it leaves a lot of folks a bit in limbo. And we only have 5 weeks. So I have a question here. And by the way, if you have questions, please, thank you for posting them in the chat. I have a question here that Greg Jackson posted, which is AI and ML. And Matt, I'll ask you specifically to weigh in on this first. So the question is, how can a device or digital health company make money using AI and ML? So since it seems the investor community and the data and AI companies want to be the ones that make profit and revenue, like how do they do that while also keeping the costs and pricing down for consumers and clinicians who are using these features?
Fascinating question. I think that it's going to become harder and harder to decouple the large language model from the device itself, or maybe said differently, from the data that the device captures. This might sound pedantic even, but it's a matter of co-developing the device with the model, with the consumer. And the consumer there is the provider and the patient, and perhaps even add into it the payer or the employer or the entire ecosystem. These things are not going to be separable anymore. And as a for instance, we had a conversation not very many months ago within our leadership team about creating an inventory of our vendors and our vended products that use AI models. And the discussion ended when we said it will be a whole hell of a lot easier to inventory those who don't use these tools than who do. And so that has all sorts of ramifications in our contracting and in our procurement and our compliance and our privacy considerations. So I don't know that I've answered the question, Drew, but to me, they become inseparable and it can't be decoupled.
I think it really depends on the value proposition at the end of the day. So if you have an AI only solution, like literally an AI only solution, I think what your primary thing that you're doing is saving the time of a human. And if that's the case, I think that you just have to make a really, really strong argument that it is actually saving a lot of cost and time. And in that case, I think that the price point is probably justified if it's literally a job that otherwise you'd be paying a person to do. But if it's, to your point, Matt, I think more and more it's coupled. I mean, ours is coupled with our software now, and I think that we're going to see more and more of that. And I think it's technology companies to bring that forward in a way that is certainly still profitable. I mean, we are trying to. I mean, every company in healthcare is trying to have a sustainable business model, right? And if it does cost more money in order to run, then make sure that the additional fees that you have to charge in order to make that happen are worth it. And if the juice isn't worth the squeeze, it probably isn't something that should be offered. Like, we shouldn't do it because we can. We should do it because it really adds value.
Part of what we're going to be looking at throughout our organization, since we have a lot of traditional manual, non-AI and augmented tools in play, but are beginning to introduce the AI-enabled tools, we will be doing a side-by-side comparison and be able to identify at what point would we be able to afford this device? At what point is the ROI worth it?
All right, we got a couple more questions here. So this is from Matt, and he says, we're working in subacute and chronic condition management. So what trends do you see outside of formal telemedicine encounters and classic high-cost RPM in terms of access models? He says, I recall there was friction around compensation reimbursement to providers for telehealth. Are the financial realities forcing a restructure of the financials of care delivery? Does value-based care change this outlook in a way that is favorable to telehealth?
I guess I can jump in and start to say that I think until a practice are really predominantly in a value-based model, it is very hard to make that case. I think particularly, I have found that working in this largely capitated model, while it has its challenges and financial limitations, it's a much more coherent way to practice, because we really can address the population thinking about what's going to be best for managing care and managing cost, regardless of the tool. So I think it makes more sense when the majority of the care is under a single model like that. But you're right, otherwise it's complicated, and we've still got one foot in each, in a fee-for-service and in a value model. So right now, no.
Yeah, it's a really interesting walk that we have to walk, right? Yeah. I don't know, Matt, if you have anything to add on that.
Only in that, I think embedded in this answer also is still some dependence on what happens between now and the end of March. And the very simple fact that, I am a believer in value-based care, pay for performance and outcomes, not just for service provision. And as a provider, it is untrue to suggest that there aren't costs on the provider side to offer virtual care, right? I mean, so sometimes regulators and others say you don't need to be reimbursed in the same way for an in-person visit as for a telehealth visit because your costs are appreciably lower. And that's only partly true. That's only partly true. So, um, that's not me trying to be a poor provider and look at me, but that is suggesting that there are costs associated for providing care virtually as there are in bricks and mortar facilities.
Yeah, absolutely. That's a great point. And, it reminds me of a conversation I was having with a population health leader mid last year. And they shared with me that they had inherited through a merger an MA contract. And that MA contract was challenging to perform against. And to improve performance by 1%, it would cost them about $30 million. And they were 3% off their benchmark. And so to your point about walking both worlds, Tracy, she said, look, what I'm doing is recommending that we just don't try to perform against the contract and focus on making up the revenue loss from fee for service. Like, that's the saner option here. Even though she's there for value-based care, it is like, that's what she wants to drive. That was her mission, right? It's a really challenging environment.
Absolutely. And we think about that all the time.
Yeah, absolutely. All right, so we have time for one more question, and then we're going to wrap. So this question, back to AI. So this is from Aubrey. AI has the potential to fundamentally shift the trajectory of interoperability, which has been a longstanding challenge in healthcare. Health systems and payers have historically taken years to adapt to change, and we've seen how this has fueled the rapid growth of direct-to-consumer convenience care models. As a virtual health and wellness coaching company that believes providers should remain central to patient care and decision-making, we're curious, how do you see AI accelerating interoperability and enabling health systems and payers to evolve more quickly? Like, beyond emergency care, how can they stay relevant in a landscape where consumers increasingly prioritize accessibility and efficiency?
AI can be a translator between technology systems to enhance or improve interoperability, much like we talked earlier about AI tools being able to translate from one language to another, or from a level of medical literacy to a different one. And so maybe there's some opportunity that we use technology to improve the technology. and interoperability is a dream of EHRs and a dream of standard language, standard technology language, so that blood pressure in one system means blood pressure in another. And so maybe, I haven't thought about this very much, to be candid, but maybe there's an opportunity to use some of these tools in that way. And then there's another, I like the last question in this that says, how can we remain relevant in the landscape? I think that some of these decisions that we have made historically, just long-standing historic decisions about, when a patient leaves a clinician's office and we say, see you in 3 months or 6 months or 1 year, sort of by rote, right? Just by rote terms, I'll see you in X weeks or X months, as opposed to come back to the clinician, condition requires it or warrants it, hopefully even before the condition warrants the return visit. And so perhaps then we can do a better job, a more precise or sensitive job of seeing who needs to be seen, when, and by whom. And so maybe there's some opportunity there to use some of these tools to make better scheduling decisions and access judgments.
I guess I would say I don't have much to add there, except that, in terms of the interoperability question, and this is a really narrow slice of that question, I think part of we just keep pushing on the EHR vendor to bring tools in that do talk with the system and that make it possible for us to integrate the data. So, and trying hard to resist the notion that the EHR vendor has to sort of approve or vet. I mean, we want them to help us integrate the tools that are of use to us. And so that's one answer. And then again, to follow up on Matt's question about relevance, again, I think that again, speaking about the population that we're taking care of, we really just have to acknowledge that in order for us to be at the center of their care, they have to trust us, and the trust has to reflect the fact that we understand what's going on in their broader lives, that their health is not just about their physical health, but also the social barriers and challenges that they're dealing with. And so to recognize and acknowledge that, and then try to facilitate them getting care without having to always come to us. I mean, I think I would say in my observations over the years, a lot of healthcare is built around the convenience, has been built around the convenience of the provider teams and less around the convenience of patients. And so to kind of try and shift that a bit is going to be important to staying relevant.
I totally agree. There's a really funny story about the early days of telehealth. Back in 2014, I was at a cardiology conference for health systems, just an internal conference. I was speaking about the future of digital health. And I had one of the very senior established cardiologists raise his hand and say, I don't understand telehealth. It doesn't seem to work. I have just as many patients missing appointments with it than without. The way we set it up is that, the patient drives to the clinic and they get into the room and they sit there and the TV monitor's pulled in. And then I'm sitting at my home and I'm waiting for them to show up and they don't show up. And I'm like, dude, you have it backwards. Like, this is supposed to be convenient for them so they don't have to drive in.
Right.
Well, this has been a great conversation. We're going to move to a final question here. We have other questions in Q&A. We'll try to get to those asynchronously if we can. So please keep pushing questions if you have them. But for a final question, we started by looking 5 years back. What were we doing 5 years ago and thinking about that we're not, or what were we thinking about then that we're now thinking very differently about? So let's end by looking 5 or 10 years out. So if we're to reconvene the session in 5 years, which would be a lot of fun, what will it change about your role? Like, what will you be thinking about in 5 years from now that you perhaps weren't thinking about today? And Tracy, why don't we start with you?
Sure, thanks. So I think I feel like we'll have the point I raised earlier about communication. I think we will need to be doing a tremendously better job than we have right now because of the potential for much more asynchronous kinds of care. And the language would need to not only address the why of the care recommendations and the care plans, but also a simplified how of how to use tools remotely and when they need to connect with a provider and when they can use the remote tools without a constant connection with a provider. I think we also will see an increasing need to respond to misinformation in social media and be our own source of information for patients that they feel they can trust and tap into and get that information in an accessible and easy way, also that speaks in a language that they can understand. And then again, speaking from our end, looking to the community for guidance about how to make this care more accessible to them and more relevant for them. So I think we have begun and will continue to move more toward engaging the community and helping design our solutions.
I love that. Thanks, Matt.
Yeah, that's beautiful. I feel like my role is one where I sit in between really, really smart people on both sides of me or all sides of me, really smart technologists who are developing amazing models and language models and AI tools and such. And then really brilliant scientists who are trying to understand how to use data and how to positively impact care delivery and clinical outcomes. And so I'm sort of in the middle, trying to create a chassis to capture data and then use data and tools most effectively and again, most equitably and with the greatest outcome. So what I hope that we'll be doing, or what I'm looking into the future for, is, what are the new data sources? How can we capture new and different data, not for the volume, like Drew said earlier, but how to effectively use these data and present them, whether they're ambiently collected, but also making certain that the data are curated and served just in time to the consumer of that information, not the data, but the information within it. And the same bolus of information or the same corpus of data might be usable in one way to a brilliant clinician, and that same information can be used very, very differently if served differently to that individual patient. So what can we do to create the next best move for an N of one? And I mean that, sort of making population-based decisions on the experience of 1 million, but applied to an N of one. And that's what I would love for us to be able to get to. That's a little bit philosophical maybe, but it's fun to think about.
Yeah, absolutely. No, this is great. Yeah, thank you all so much. Thank you everyone for joining. Tracy, Matt, thank you. This has been an exciting conversation. I really appreciate it. And I'd love to do it again soon sometime. So with that, everybody, thank you so much. Have a great rest of the day. And we will be sending the recording around to you within the next couple of days.